It is for us a great pleasure to be here with you today. I will come down to this place first because I feel safer. And let me thank these two companies, FBI Equipment and Optopol Technology, because they enabled this session. We have no disclosures to make. I have learned through speaking with many of you. I'm a happy user of these devices, as you all are. And I am a friend with Mr. Facundo Bahamonde, the leader of this company, and the person who asked us to come and present to you. The title of this course, Clinical Foundations and Aspects of Macular Angiotomography. Before we get started, I'd like to ask a favor of you. Please make a list. It's an exercise, a mental exercise. Make a list of 5 pathologies, retinal pathologies, you would be interested in studying the vascular pathology, whether retinal or choroidal. And also make a mental list of 5 pathologies you would not be interested in studying that pathology. As you draw that list, let me introduce you to our speakers. Dr. Ximena Mira Lorenzo, she's an ophthalmologist specialized in retinal and vitreous body. She graduated from Nuestra Señora de la Luz Hospital. Dr. Antonio Lopez Bolaños, an ophthalmologist specialized in retinal and vitreous body. He has graduated from the Conde Valenciana Hospital, and he is a member of the retinal department in such hospital. And I'm Dr. Rosa Garnica Hayashi. I'm an ophthalmologist specialized in retinal and vitreous body, and I am a graduate of Conde de Valenciana Hospital. Let me walk you through the talk. We'll have an introduction, foundations of angiotomography, nothing new, but if our foundations are solid, then we will take a look at an angiotomography, an angio-OCT, and understand what we are looking. Then Dr. Bolaños will talk about how we are going to interpret the OCT indications, and in concluding, Dr. Ximena Mira will land this information for us. You will just strengthen your knowledge, and she will be presenting clinical cases. If time allows, then we will have questions and answers and conclusions. How did you go with the list? I'm sure that it's done by all of you. And I should say that the one you found easier is the one with pathologies you are interested in studying the vasculature. This is because the retinal vascular pathology is extensive. It is a pathology where there are alterations of retinal and choroidal vessels. If we draw a list, then we can see pathologies such as congenital pathologies, traumatic pathologies, tumoral pathologies, infectious, inflammatory, the queen of them all, diabetic, metabolic diabetic pathologies, occlusive pathologies, and then we come down to idiopathic ones. So vascular pathology is very big, and we, as retinologists or ophthalmologists, are interested in studying the vascular pathology. So it comes in handy to know how the eye vasculature is conformed in order to then understand how what we get to see can be accounted by the physiopathology. When it comes to the retina, there's 2 plexus or 2 vascular affluents. The choroidal one that stems from ciliary arteries and retinal vessels that stems from the central retinal artery. Choroidal vessels are in charge of oxygen and nutrient exchange and of disposing of waste material. It is on the external portion of the retina. Retinal vessels are in charge of exchange mechanisms, but on the 2 internal portions of the retina. So, if we are asked to describe the retinal vasculature, then I should say that retinal vessels will be divided into superficial plexus running below the nervous fibers, the intermediate one running below the ganglion cells and the deep one below the nuclear internal layer. And what comes next is an avascular zone. We know that choroidal vessels supply blood to this. I went back to the basics because today we have a piece of equipment that has brought us all together that allows us to see all these plexus as no other device ever did before. We talk about retinal vessels and choroidal vessels. This device allows us to see all these plexus and study them. And this is why we have to go back to the basics of anatomy. So let's go back to the question, which are our study methods? Without any doubt, the queen is physical exploration, that is ophthalmological exploration. Thanks to this, we will come down to a diagnosis, we will come down to diagnostic suspicion, and we will decide whether we need to carry out a paraclinical study or not. If we decided to administer a paraclinical test to the patient, the next question that comes along is, what am I looking for? What do I want to find? And which tests will I indicate? What am I looking for? Well, that will not just mean to take a clinical photo, but I have to monitor how progression is detected on anerythrites. Or we may carry out a fluorescein angiography for retinal vessels or an indocyanine green test to see choroidal vessels. Angiography has been in place since 1960. It was and continues to be the gold standard to study some pathologies. If we get to dim the light, then you will see the angiography. Your brain is already trained, and then you say, we are on this trace, we are in hypo or hyperfluorescence. You know all the phases. Your brain is trained to know what is going on here. But since 2014, we've had this device, angio-OCT, angiotomography. So the mandatory question is, are they comparable? They both study the vasculature, but are they comparable? Are they equivalent? If we travel back in time and then we go back to 2014, and I, with a bias, and I underscore the term bias, I show you this slide and I say, this is the fluorescein angiography. And on this case, you have an angio-OCT. Could your eyes notice the difference? You might as well say they are almost alike. But then I say, here I had to inject contrast medium on the patient, but not in this case. Again, there's bias. This is a paper in 2018 that talks about what could be the case with angio-OCT. In reality, the greatest majority of devices currently show us, well, you know, angio-OCTs are 3 by 3 or 6 by 6. Optopol, in the new version, allows us to see angio-OCTs of 12 by 12 or 15 by 15 or carry out mosaic reconstructions such as this. This allows us to see the posterior pole. So the first issue that we have to find out is, when should I indicate an angio-OCT to patients? When I'm interested in finding something on the posterior pole. If I want to find something about the peripheral pathology, hardly will I indicate an angio-OCT. This is a 12 by 12 slice, but this is 3 by 3. So this will only be useful for me to see the fovea. And this is 6 by 6. And it will barely help me see the macula. Let me go back to images. The smaller the amplitude, the greater the definition. And the greater the amplitude, the smaller the definition, or the lesser the definition. How about the next question? Will I take it just as a fluoroangiography, as an FAG, Of course not, because you won't be pondering the same elements. This is why we have to go back to basics. I'm sure you know them all, but we will strengthen our knowledge of what is it that we are considering. When faced with a new technology, we are faced with a new learning curve, so we have to go back to square zero. Let's erase the knowledge for us to understand the new technology. This assesses motion, movement of erythrocytes. And how does it do so? I say that this is through repetitive horizontal and vertical slices that are correlated to bring about a three-dimensional image on a coronal field. Maybe I didn't say much, or I was not too innovative in my explanation, but let's break down this to the detail. Let's imagine that you are my retina. You are the subjects of study. Then I say, I'll have 20 photographers come along, and I'll have 10 on the vertical axis and 10 of them on the horizontal axis. And I ask photographers to shoot all of you in a time span, let's say 30 seconds, so they will have to shoot photos of all of you, and I'll say, ready, steady, go, and all of them will go. Let's imagine that each one of them took 10 photos of you. 10 times 20 photographers means that in a 30-second time span, I have gathered 200 photos of you. This is how it goes. This is how the device works, but these are not photos. They are scans, tomographies. These are repetitive scans on the same zone in a given time span in a vertical direction, and the same applies to the horizontal direction. So in that while, depending on the device, we will have gathered 230 to 512 bidimensional tomographies. What do I do with 500 of them? What does the unit do with all those scans? The advantage of having these tomographies on the horizontal and vertical axis is that the device can reconstruct them in a three-dimensional way. There's three-dimensional information. I'm sure that we've all played with this. The flip book or a folioscope. There's images and we flip it, and then our brain detects movement, and this is what the mechanism of the device does. How does it go about it? Well, the famous term is that it decorrelates the whole thing. What do we mean by that? Let me show you this clock. You see that the hands are moving. The hands are moving and the pendulum is ringing. And let's do the same exercise. Let's take photos of it in a time span. The thing is that we accrue 3 photos, but they are not comparable with one another. And then I say, take a look at this pixel by pixel to notice differences. And if you encounter any difference, then you will paint that difference in white. This is what the device does. When it finds differences among all these photos, in this case, its scans, the device will paint them white because it means that there was a decorrelation. Let's follow the same example. Let's now pause the clock and let's take photos again. Let's analyze pixel by pixel. And if we do not encounter any differences in the last few photos, this means that there was no decorrelation and the device will paint it black. So far, so easy. So I go back to the beginning. So decorrelation is a measure of similarity among signals to find differences based on time. And I don't know whether you've heard of Michael Murphy. Perceptual art is what he does. He uses several spheres in different dimensions, and he ends up building an image that can be understood by the human brain. And this is how the device works. We are physicians, And it is not the first time we get to see any such image. We've seen those in scans. Our brain already understands that we might be at a cortical level or at an orbital level, and this is how things fare. So we have mode A and mode B. You already mastered them. And we have scans in a horizontal direction and in a vertical direction. Then the device can bring about a 3D image. So the device will show this on plane C, on the coronal plane. And then it will yield these images. So if I ask how an angiotomography, an angio-OCT works, this is what it does. It takes repetitive scans horizontally and vertically, it decorrelates them, and it yields a coronal image. And so this is an easy understanding of how an angio-OCT works. Of course, we have to have everything in place. If this will assess movement and if the flow is slow, then we will take a photo. And as the erythrocyte comes along, then we are already done. I didn't take a photo of you. Well, this might be the case with aneurysms. We know that there's flow in aneurysms, but the flow is slow, and the device is so fast that it sometimes does not detect the flow. This is why people say that angio-OCT is not good enough for aneurysms. Well, there's some that are detected, others are not. This depends on the speed of the flow. We should also understand, as we already said, these are not photos, these are scans, and therefore the device can segment and show us each layer. This is why we can see the superficial layer, the deep plexus, and then we can understand all these layers. And the device can segment this in very many layers. And the next question that comes along is, will it be useful for me to see all these layers? Well, we can currently say that this is where we have to train our brain into detecting. And this is what the device shows us. The superficial plexus, the deep plexus, the avascular zone, or the avascular plexus, and the choriocapillary layer. These are the 4 layers our brain has to learn to study in an angio-OCT. So the superficial plexus, what is it that we're going to see here? The retinal vessels and the ramifications to the foveal avascular zone. We will get to see the deep vascular plexus. Here we do not see the intermediate one. Well, it's actually a summation between the two of them. And the deep one ramifies into the arachnoidal surface. And this is why we see this arachnoidal image. Here, the vascular arcades disappear, and this is how we see the deep vascular plexus. The avascular one, this one, it is avascular. There are no blood vessels, so we get to see an image with total decorrelation. And then the choriocapillaris, where we can move the row further down, but the arrow further down, but the choriocapillaris allows us to see the more superficial part of the choroids. There's a granular aspect, and as we grow old, it gets atrophied, and we get to see a thicker and thicker choriocapillaris as time goes by. We also have to understand the famous in phase. Initially, people would talk about whether they've seen it ever. It is not the photo in black and white, because we now know that that in phase is given by a tomographic reconstruction. It is not based on photos, but it is some sort of histological representation of the tissue rather than of blood vessels. And on in phase, what matters is that we can see here cysts, and we can also see them there. So we come down to these 4 phases that the angio OCT shows us we can already identify them, but what comes along is the most difficult part. When we are trained to know what is normal, then we have to train our brain to detect what is not normal. I therefore give the floor to Dr. Lopez Bolaños, who will talk about the basis for interpreting the angio-OCT and its indications. Thank you so much. Will you please help me show the screen? Just let me get myself together. Okay, I'll talk about how to interpret OCTA or angio-OCT. It is very relevant for us to know that this technology didn't exist before. It's a major breakthrough, the fact that we can see the retina in a segmented manner. I say this because we have a dated system, fluoroangiography, FAG, which nonetheless continues to be useful even today when in 2022. But we need to know the differences between the two of them. Please remember that angio-OCT looks at vascular structure, whereas FAG takes a look at the flow dynamics. It is important to understand this because they both complement one another. Towards the end of my lecture, we will see a few features of one and the other. Dr. Garnica told you how the machine is a segmentation or generates a segmentation on retinal layers on the macular area. It makes cuts or slices showing us what we want to see. She said that not all areas are sliced because that is not that relevant for our exploration based on what we want to know considering our patient's pathology. We have to focus on segmentation areas, the internal limiting membrane, the internal and external plexiform layers, and Bruch's membrane. So when the device is used to know what exists on the anterior portion of the macular area to the deep limiting membrane, then what we have is the vitreous body. If there is movement, it is in one color. If there is no movement, it is black. We should not study anything here. We are not interested in knowing what exists there. But if we cut the internal limiting membrane to the internal plexiform layer, the penetrance is around 60 microns. So we have the representation of the superficial plexus. If we cut the internal plexiform layer to the external plexiform layer, then we are trying to see the other two plexus, the intermediate and the deep one. And there are a few machines that show us the difference between the intermediate and the deep, but for practical purposes, that serves no purpose. We just have to focus on the deep plexus. When we segment the external plexiform layer to the Bruch's membrane, this is the external retina that is avascular. Then we will have this black image. There's a few details that you can see here. This is gray, and this refers to a number of problems that machines can have, and we will talk about this in more detail later on. If we segment, if we slice Bruch's membrane down, then we have several options. We may have the choriocapillaris, but also machines with greater penetration will show us a Sattler's layer, the one with medium choroidal vessels, or the large choroidal vessels layer, as can be seen here. All these parts, all these segmentations will help us study the pathology of our patients. What is it that we're going to see? We will first take a look at the superficial avascular plexus. What are the characteristics? They are not the same. These are lengthened vessels, primary vessels, that move on to temporal arcades to the center of the macula, and they surround the foveal avascular zone. There is a mesh of blood vessels that is smaller. They are in a regular mesh surrounding the foveal avascular zone. These are the small little vessels. You know, this is the foveal avascular zone. It is important to study this in diabetic patients where there might be an increase foveal avascular zone, and it is important to study this. A few tests came about. First, it is important that the test should always be consistently done with the same machine. We cannot cross-compare between different brands. That is just not possible. Here you can see the sizes that this foveal avascular zone can produce, 250 or 270 microns. It is important to know that the foveal avascular zone on the deep plexus is bigger. This is 350 microns on average, depending on the machine. This is the superficial plexus, but I want to anticipate a few features. It is important for us to always relate against the patient's anatomy, in this case, using the structural mode. If you see the foveal avascular zone in all three images, this is different. It differs in all three. You could say this and this. Well, the patient must be diabetic. There is increase of the foveal avascular zone. But if you take a closer look at the center of the macular area on the fovea, in all three, they are different. So the foveal depression is here smaller, bigger, and intermediate. Depending on this, the foveal avascular zone will result. So you always have to relate this to the OCTA. We can measure the vascular density. Well, with age, the number of vessels will decrease. This is especially on the superficial vessel, on the superficial plexus. There's different sizes, 3 by 3 or 6 by 6. These are tests that are available. These are useful tools to assess our patients. We therefore have the following. On your left, we have a normal superficial plexus. We see that the center one is not normal. And well, since we talk about decorrelation or lack of correlation or absent correlation, these are terms that are kind of confusing. So when we interpret these tests, well, we should say that in this area, if we correlate this to a venous ramus occlusion, then there is an area with unperfusion, with lack of perfusion. This is easier than getting all confused with mixing terms. This is a diabetic patient with enlarged foveal avascular zone, and there we see a microaneurysm. As Dr. Garnica said, not all of them will be adequately seen. The deep plexus, what about its characteristic? These are far smaller vessels. We take into consideration two of them, the intermediate and the deep one, and there is an orderly pattern. They are smaller and well distributed. It is some sort of granular, regular shape. These are the characteristics of the deep vascular plexus. The vascular zone that is bigger. This is loss of architecture on the photo that is having these arrows all around. This is because there is no movement. There is an ischemic zone with venous occlusion. The external retina, as I said, it should be seen black. There are a few artifacts here, but it is black because there are no blood vessels. So when there are disturbances at this level, there's presence of blood vessels that will be seen here, as can be detected on these images, such as choroidal neovascularization in an age-related macular degeneration patient. We can see the new vessel formation in this neovascular membrane. that is highlighted with the blue arrow. So this machine in particular shows this result, this report. So we have the superficial vascular plexus, the deep vascular plexus, the avascular external retina, and the choriocapillaris. In other devices, you can also see deeper, much deeper layers of the choroids. We have an end phase, which, as Dr. Garnica said, we are not getting to see blood vessels there, but we just take a look at the tissular structure in order to have an orientation on where these lesions are located. There is a color scheme that will guide us more easily, and mode B should always be there in place to know about structures. We know where damage is located and to specify it more easily. This is the normal interpretation of an OCTA or an angio-OCT. Let's talk about artifacts. In an FAG, we can also find artifacts, but they are actually not significant. They won't cause any trouble interpreting them. Here, it is nonetheless more important. What is an artifact? It is an image that we see on the study, but it doesn't exist in real life, and this can be confusing. Which are them? There's lots of artifacts. Machines and softwares have increasingly mastered deleting these artifacts, but a few of them still persist even today. These are the most important ones: the projection artifact, the segmentation artifact, and the motion artifact, but we can come across a few more. Let's talk about them. What factors can cause this problem? This is done quite quickly, but exactly because of how quickly the test is administered, a patient's age, an uncooperative patient, an elderly person, or a child can be challenging, and then these artifacts may result. Poor visual acuity, a poor fixation, a pupil smaller than 2 millimeters. We sometimes have to dilate the patient's pupil. We generally don't do this for this test. However, the presence of opacities, such as cataracts, the presence of a too big anterior-posterior axis in patients with myopia, or in this case, macular edema as well, of any type and nature. This is why I'm listing this as part of the examples. What type of artifacts do we encounter? Let's talk about some of them. Generalized signal loss. This is typical. I get patients referred by other doctors, and unluckily so, opacities are big on the cornea or cataract opacities, so the image is not adequate. We cannot interpret it well, and this is why I am showing it here. And that happens frequently. Localized signal loss. As can be seen on this image, we see this spot. And even though it is not limited by vessels, even so, we might believe that damage or disturbance is on the retinal tissue, and that is not the case. This is some sort of bamboo mesh, and the shadow of this mesh is on the anterior portion towards the posterior portion, and this can result in this image, such as is the case with vitreal opacities. Here we may see floaters, vitreal cysts, and we have to be careful and know that the patient has these disturbances in order to know that we will find localized signal losses at times with these patients. Well, another cause, normal eye movement. An uncooperative patient with constant blinking. Optopol machine asks patients to blink normally, and it seems that precisely at that moment, patients end up blinking permanently, so that's no longer normal blinking. And that tends to happen. We might have nystagmus disturbances, and therefore have these artifacts that result from that. And that's not only it, but we also have cases that there's duplication of vasculature because of that same movement. This is the same vessel. So it is very relevant to know this type of artifacts. Projection artifacts. This is a shadow. It looks very much like the one I showed before, but this means that from the very same retinal layers, we have the shadow of blood vessels of a layer that is more internally located. In this case, for instance, you can see that in this patient there is segmentation by the machine. It is on the external retina. And on the image, it looks as if it were the superficial plexus. So we have to really be careful in knowing where the machine is segmenting in order to determine these type of things. There are not that big artifacts present like the one here anymore, but I just wanted to bring this to your attention just so you know that it exists and it may cause a poor interpretation. Segmentation errors. This drawing, you know, the quadricles are regularly placed. The machine automatically looks at where to cut. It slices here without any issue. But what happens if we have an image like this one? Let's think about diabetic macular edema. Rather than having a slice further ahead, it will be done further back, and it will be done in an irregular manner. So the image is not real. So, well, this segmentation error can be triggered by several things: atrophy, edema because of epiretinal edema, lamellar macular holes, or the presence of macular edema. So these may trigger segmentation errors. Another example here, you know, the machine is segmenting poorly. It is crossing the center of the cyst. So when we see the angio OCT, we could say that there's lots of ischemic zones. So this segmentation can be corrected manually, and therefore the machine is here, we correct it, we move the lines, we release the cyst, and if you take a closer look, there were not that many ischemic zones on this patient. So you can do this manually. But Optopol is now offering a software program. This patient has an age-related macular degeneration, and segmentation is not properly done. It could be corrected manually, but the unit, the piece of equipment, does it automatically already. This is a very good advantage to avoid segmentation errors. And in concluding, just so you know how to tell the presence of artifacts, that in spite of all this, 91% of interpretations are accurate. But please remember to correlate the clinical manifestations, the clinical picture, the bidimensional OCT, and other considerations for a good diagnostic treatment and follow-up of these patients. Let's talk about the indications for our patients who will undergo an angio-OCT. We saw the superficial and deep plexus. If we want to see a disturbance at this level, then we think that the patient may have diabetic retinopathy, venous occlusion, or arterial occlusion. But if the problem is on the external retina, that is avascular, then we are looking for neovessel formation or in age-related macular degeneration in a patient with myopia or in pachychoroidal diseases. And if it is more external, then we will be looking for pachychoroidal diseases or uveitis. So these are the indications, the general indications. To use this, please remember that there's lots of fragmentation in these tests. We still do not have any given diagnosis that is absolutely dependent on an OCTA, except for a few pathologies, such as neovascularization in age-related macular degenerations, in myopia, and in other pathologies. This is what this is more useful for when managing our patients. And before the end, I should say that do we talk about OCTA against FAG? No, it is not an opposition. there's a complementation with one another. Fluoroangiography hasn't fallen into lack of use or disuse. And these are just a few differences between one and the other. OCTA is not invasive. You can get images quickly. Interpretation takes a little longer, however. FAG, well, you see the image, and as soon as you see the image, you can see whether the patient has neovessel formation. In OCTA, it takes you a longer time. We may see segmentations in several layers. We may cross hemorrhagic zones to see other layers in spite of hemorrhage, unlike with FAG, and we are detecting flow rather than loss. And fields are far smaller than in FAG. Thank you very much. I hope you could follow me. And now we have Dr. Ximena Mira with some practical cases in connection to OCTA. Thank you very much. I'd like to thank Facundo and Optopol for having invited me. And I'd like to thank you for joining us. Let us now mix and match whatever was very simply explained by my colleagues, Rosa Antonio, after having read millions of papers, conveyed a very good understanding of angio-OCT. As Tonio said, we have to make a clinical correlation with fundus, with fluoroangiography, with OCT, and whatnot. And I will share with you two clinical cases and some examples where angio-OCT makes a difference. Let's get started with the first case. This is a case of a female patient, 24 years old. She was quite anxious when I interviewed her, and she said that she had some episodes of anxiety attacks. She was being treated by the psychologist because she had blepharospasm. She says she didn't have any zoonosis, no relevant family history, but when I interviewed her, I noticed her as a very anxious person. She was referred to me to manage ocular toxoplasmosis. She said that 2 years ago she started having blurred vision on her left eyes with metamorphopsias, and she cannot have a vision of 20/20 with both eyes. She refers major periocular pain and headache. The right eye has 20/200, it improves to 20/80, the left eye with metamorphopsias from 20/50, it does not correct, and she sees distortions. Upon refraction, we see some difference, but with her graduation, she reaches 20/20 on the right eye, but the left eye remains at 20/30. Biomacroscopy, no relevant findings. We see some retrokeratic deposits, cellularity. And on the fundus, we get to see that on the right eye, the oblique papilla can be seen, and the rest of the images see no alterations. But on her left eye, we see this peripapillar atrophy, and on the posterior pole, we see this whitish, yellowish subretinal images with some distance between them, and we can get to see some pigment changes and detachment of the pigmented epithelium on the retina. On the remaining of the equator and behind it, no alterations. We just saw it on the posterior pole. We ordered an FAG, and filling times were preserved, and we started seeing that early on she shows hyperfluorescence that increases as phases go by, and we see these zones of whitish yellowish lesions, hyperfluorescent halo because of RPE atrophy. and because of chorioretinal atrophy and because of subretinal fibrosis. We see the structural mode B OCT with Rebo and X. This is a bi-scan. It is 12 by 12. We see increased thickness on halar layer vessels with some compression of the choriocapillar layer. The remaining external and external retinal layers are normal. On the left eye, we get to see the issue, and it is important not to only ask angio-OCT. Tonio mentioned this, and I say it again. We have to correlate mode B with angio-OCT. We find here that when we see defects on the external retinal layers, we see below them increased thickness of the choroidal layer. We see compression of choriocapillaris layer and changes on the external layers of the retina. There's loss of continuity of the external membrane on the ellipsoid zone, detachment of the pigmental epithelium, hyperreflective material, the whitish zones that are seen on the fundus. This is fibrinoid tissue. And just take a look at how we see major atrophy of external layers in connection to these wedge images. Many times, this might simulate intraretinal fluid. These images get started from the external plexiformis, and they make a deep dive to the external layers of the retina. These are apoptosis from the external plexiformis down to the photoreceptors and the RPE. If we follow this patient over time, this wedge will reach from here to there. We see this hyperreflective material, fibrinoid tissue, and the loss of continuity of external retinal layers. We see how the light is transmitted to the choroid because there is loss of cells and of nuclei. So we see these zones of epithelium atrophy, the pigmented retinal epithelium, and this fibrinoid material in blue, and detachment of the retina pigmented epithelium. So we do ask for an angio-OCT, and let's practice all that we heard so far. Here we have the superficial plexus with large vessels. Vascular zones should be round and regular. We always have to test both eyes to assess bilaterally and symmetrically the deep plexus with greater anastomosis, and this is why we see smaller vessels. And this plexus, just check out on how some of the anastomosis of the vascular plexus of the deep one are projecting. It should be black. Some articles refer to this as a black box. And some anastomosis are projecting from the deep vascular plexus, but there are no abnormalities. On the choriocapillar, we used to see these thickened vessels on the choroids, so we get to see some patches. These are called halos, black halos, that cause damage on the choriocapillar. In face, this plexus where we will see histological slices on a coronal view and vascular density. This device correlates this to mode B OCT, and then we can segment wherever we want to take a look at. And so what did we find on this angio-OCT of the left eye? We see that on the external plexus, where there should be pigments, we see a neovascular membrane, and within them there's lots of classifications in connection to morphology and typology. There is one that is called filamentous, which is specific to choroid membranes. And on the choriocapillaris layer, we see this membrane with a halo, and it talks about damage on the choriocapillaris plexus, and it talks about activity. Segmentation is being done on the retina, pigmented epithelium, and on Bruch's membrane. We see increased flow. We might otherwise notice it in the B mode, where we see detachment of the pigmented epithelium with whitish areas. So we probably didn't even think about a neovascular membrane. We asked for an autofluorescence, and so the right eye is normal. The left eye, well, we see this hyperring with hyperfluorescence on the periphery. It talks about detachment of the pigmented epithelium and two areas with atrophy of the pigmented epithelium. So far, the patient was tested many times. She was referred because of a typical ocular toxoplasmosis, which I didn't agree with, but we had to rule out whether there was any atypical manifestation or a severe chronic serous chorioretinopathy. This per se has a different spectrum. It is quite impressive, and within the pachychoroid spectrum, we had to rule out neovasculopathy because of pachychoroids. And so we started studying it, and when reviewing the literature, we see that angio-OCT helps us reach diagnosis, not just because of diagnosing the neovascular membrane, but also in ruling out other pathologies. In punctate outer retinopathy, it might look similar on the fundus. The yellow box is our patient. These are images reported on the punctate outer retinopathy, but in autofluorescence, everything is hypofluorescence. There is no areas of hyperfluorescence, but the OCT could be very similar. It modifies the external layers on the first few phases to then modify the internal layers and then generate a vitreitis. What helps us do the differential diagnosis in these multimodal images terms is OCT, because the punctate outer retinopathy shows increased foveal avascular zone, which our patient doesn't show. Our patient has a type 1 neovascular membrane. Paraclinic tests are done for toxoplasmosis. IgM titers were very low. This rules out any such activity. So we followed up on her. And I remember that chronic central serous chorioretinopathy may have an accumulation of fibrin. These are the images reported by Dr. Janussi. This fibrin happens in women with some hormonal alterations, excessive estrogens, or in pregnancy. This is where we are going to see these lesions. This is where we're going to see these lesions, these whitish, yellowish lesions, as is the case with our patient. But when we carried out all other correlations, of course, in a chronic central serous chorioretinopathy, we have several patches of atrophy. We have a tie shape, a drop of pigmental changes on the retina. We always have serious retinal detachments that are chronic, and hotspots as well. Our patient, however, didn't have any such signs. So after assessing everything, well, at some point, I thought this could be the case with her. We see these extensive areas described on the central serous layer. In elderly patients, we can think it is an age-related macular degeneration. These extensive areas of diffuse atrophy of the retinal pigment, but in order for us to make any such diagnosis, areas should exceed 5 areas of a diameter disc from the papilla. And we see these wedge images. These are quite similar in our patient. Increased choroid thickness, external tubular degeneration. And due to these images, I was able to make this correlation, but it didn't really agree with what I saw before. So our final diagnosis was pachychoroid neovasculopathy because of pachychoroid spectrum with this accumulation of fibrin. and we see the neovascular membrane. Since she is a patient with type A personality, she got injected. And in 2 weeks' time, she came to the office for me to see whether everything was all right. And since I'm a curious person, since I had the equipment available, I measured visual acuity, another OCT, and another angio OCT. And soon after, the anti-angiogenic that we injected her, that was aflibercept, in a week, there was a reduction of the neovascular membrane that could be measured, and there was a reduction in the flow, and her sight was 20/50. In a week, she would just see 20/20, and if I had just done a mode B angio-OCT, I may not have seen any structural change, and she improved. But whenever we can assess the effect of treatment on the different plexus on neovascular membranes, then we could understand why metamorphopsia disappeared and why visual acuity improved. That was because the neovascular membrane was reduced and the flow was reduced as well. We injected her with aflibercept, and I don't refer them all to the psychologist because I don't know how they might take it, but I talk a lot about their personality, doing things for them, doing exercise, whatever works for them, to try to see them as a whole and provide them more tools for them to improve and avoid having any such recurrences. She currently has an eyesight of 20/20, and she continues to go to see me because she is a type A personality. So these are the three differential diagnoses, and this is neovasculopathy in the pachychoroid spectrum. And OCT, angio-OCT, and fluorangio are really helpful in us reaching a diagnosis, making treatments, and following up on patients quite well. These are my lessons in this case. This is the second case. This will go quicker. It is far more common, but I believe that we are somehow underdiagnosing it. She's a patient that was referred by two other colleagues. She comes to see me for a third opinion. She's a female patient who is 46. She's a heavy smoker. She almost smokes 1 pack a day. She's been recently diagnosed with hypertension. She started her systemic treatment. The rest is not that important in connection to her history. On September 22, she started having amaurosis fugax on her right eye for 30 seconds. A few hours later, she had decreased eyesight on the right eye. She's a patient who was tested before, so the first few tests have not been prescribed by me. The right eye visual acuity 2400. It improved to 2090. With refraction, it stayed there, and left eye 2020. The pupil reflexes were preserved on both eyes. Everything was normal. No rubiosis and normal IOP. This is the fundus. When checking the fundus of this patient, well, there is nothing that calls our attention that much. Maybe the vascular tortuosity, these arteriovenous crossings. And with this image, after seeing her and taking a look at the photo, I couldn't get much information. She had this FAG, and we can see on seconds 26, as soon as the artery is filling up, then at second 30, it doesn't really paint. The arteriovenous flow is not painted. So there is delayed arteriovenous filling with an intraretinal hemorrhage. So we might think about central venous occlusion with no conventional findings. So I do this mode B OCT, and we find this hyperreflective layer on the internal nuclear layer that is known as paracentral acute maculopathy. It is ischemia on the nuclear interlayer, on the deep vascular plexus. And if we order an angio-OCT, it looks strange. It looks quite different from what Rosa Antonio showed. We see that on the superficial plexus, we don't see big vessels. The deep plexus doesn't show telangiectasias. On the external layer, we see everything normal. And in phase here is what becomes relevant in many pathologies because of the histological cuts Rosa mentioned. We see this pattern on the bed, which was diagnosed by Dr. Saraf on this paracentral maculopathy, PAM. This is perivenular ischemia. So if we could have greater definition, these would be the vessels, this would be one vessel, and this affects venules. So if we study it deeply, then this ischemia on the deep vascular plexus, which on the in phase we can see that ischemia is around venules, then we can carry out this diagnosis of a PAM secondary to a central retinal vein occlusion without typical clinical findings. And I wanted to show a video in order to help you better understand these end-phase images. So as Rosa was saying, this will become relevant, and it is part of angio-OCT. As Rosa says, it takes vertical and horizontal photos, and when we turn it around, we see the coronal part, and we have to segment in order to take a look at it. So this patient, we could follow up on her. I ordered complementary tests. Blood chemistry was normal and a normal lipid profile, among other values. We followed up on her a month later. Her vision fluctuated between 2100 and 2090. But here is where in phase will give us greater information, and it actually shows us the plexus on the bed that is present 1 month later. Just see how on the next month the layout of these areas changes, they become more diffuse, and by April, the pattern changes completely, and her vision comes down. It's been described, and this is all the follow-up, that there is some central ischemia that starts to happen around perivenules, and this ischemia is extended outwards, starts to extend outwards. The pattern changes, and when ischemia extends, visual acuity comes down, and the patient did not manage to improve from 20 to 100. If you read, there's cases of PAM that improve to 20/20, others do not. So I believe that this will be stated by the described patterns. There is the globular pattern in ciliary retinal artery occlusions. There is the fern pattern as well, which is the most common one in central occlusions. And let's now talk about daily life cases. These are quick examples to conclude. Where do we have to carry out an angio-OCT? This was mentioned by Tony, Tonio, the artifacts. We have to see the patient as a whole. We got the equipment, we did OCTs across the board to see how it would come out. So next to the office, there's a cafeteria, and we knew that the waiter had good eyesight. He was a patient of our office, so we asked him to undergo these tests. These are the angio-OCTs. So they called me, "What is this?" And I don't know. It might be an area of hypoperfusion, but he's a healthy patient. Okay, he got called upon. We checked him. He got dilated, and he had a great condensation on the vitreous body. these can simulate these artifacts, and we might then run the risk of poor diagnosis. So we need to clinically correlate mode V, angio-OCT, and other multimodal approaches. We have the non-exudative neovascular membranes. These are known as flat, irregular epithelial detachments. These are flat and irregular, and if we administer an angio-OCT, we see these neovascular membranes, and whenever we measure and quantify it, it highlights, it stands out. These are active neovascular membranes, which in mode B we wouldn't have diagnosed because there's no intraretinal fluid, there's no cysts. It is just a flat, irregular detachment of the pigmented epithelium. And when we do an angio-OCT, it appears, and this is the neovascular membrane. So once we get started with an anti-angiogenic treatment, angio-OCT helps us in these three last pathologies that Tonio mentioned in order to follow up on these patients. In connection to neovascular membrane, there's a lot of information, forms, types, the repetition of vascularity, and the loops. But once they respond, then we can see this rectifications and thickening of vessels, lost loops around, and a repetition of these loops that can be construed of as fractality. And what are the most common cases of macular edemas? Do we have to carry out angio-OCTs? If you find big cysts in diabetic macular edema with a considerable base and height, greater than 450 microns, then we have to carry out an angio-OCT because these are patients that are mimicking ischemias. So I say, let's inject them, let's implant them dexamethasone, which is very expensive, or an anti-angiogenic, but all of a sudden the patient doesn't improve because they actually had ischemia. And in these examples of large and mid and small cysts, well, this is a patient who had a diabetic macular edema, and when it comes to carrying out an angio-OCT, we see this irregularity on the foveal vascular zone increased. Concentration and extension. We can treat them, but with an excellent communication with patients so that they are told that they might not improve because of ischemia and because of the foveal increase. When we increase the mosaic, we see the extension, the capillary closings in this patient. And in diabetic macular edema, when we have disorganization of the external layers of the retina, we need to assess the deep vascular plexus because there might be changes there. And in the presence of changes, since 2017, Dr. Lee in an SRS mentioned that when we have any such changes in a deep vascular plexus because of macular edema and diabetic retinopathy, these patients may not have a good anti-angiogenic response. So we are injecting them all the time, but since they have damage at the external plexiform layers, they are not very good candidates, even though we have to try to inject them, but we have to explain what the prognostic factor is. And in closing, I believe that in phase will get us going in the next few meetings. Whenever we carry out cuts, we may have images of the epiretinal images, and you see yourself, with clamps on this fold. We will do the membranectomy, and then we can assess cystoid macular edema, how the image looks like, how cysts look like that may mimic ischemia, and this is why we have to correlate in order to make sure that this is ischemia. And in some articles, they mention that end phase, in some cases, we might have the same information as autofluorescence in age-related macular degeneration. This is so far as our presentation goes. And well, thank you so much for joining us.